So good afternoon, everyone. As we are already running quite late, so I'd like to start the session. So we, this is the Trauma 1 session, the free paper session, and every talk is about 5 minutes. The paper duration is 5 minutes, and 2 questions after every talk will be allowed. So I call upon the first speaker, Dr. Riya Utpal Mazumdar. Dr. Riya is here? Yes. So, the time, the
5 minutes.
Okay.
5 minutes.
Do I start?
Yeah, please start.
Today I'll be presenting a paper on demographic and clinical profile of intimate partner violence related ocular injuries. I cannot move the slide.
The slides.
Intimate partner
Please.
violence is one of the most common and underrepresented forms of violence amongst women, with rates up to 10 to 69%. These account for 34 to 73% of facial trauma, out of which 94% involve the head and neck region and 45% involve the eyes. However, poor detection rates, limited evaluation in the ER, and a comprehensive lack of research results in the underrepresentation of IPV injuries. This study aims to identify demographic and clinical risk factors for IPV in India and correlate them with visual prognosis, and to draw out a predictive model to assess the severity of ocular injuries based on the demographic profile of the subjects. This is a retrospective cross-sectional ER-based study conducted over a course of 1 year, and analysis was done to draw out the demographic and clinical correlations between the ocular injuries and demographic variables. Inclusion criteria included patients with a history of IPV who had not received prior treatment or had not been reviewed previously for these injuries. Patients who were also reviewed only for the first time and had given prior informed consent. Exclusion criteria, patients with other associated traumatic history, injuries with prior history of IPV injuries, or were on systemic treatment for other bodily injuries. The information was adequately analyzed, and the results are as follows. 54% of the patients were in the age group of 30 to 40 years, with a mean age being 30 years. Younger age groups had higher BCVAs, and the maximum rate of IPV injuries was noted in Prasad Economic Scale 4. This is the graph that showed the age and the demographic profile against the visual acuity. The ocular injuries was found to most commonly involve the conjunctiva, followed by eyelid and vitreoretinal injuries. 65% of the IPV patients presented within 7 days of injuries, among which 47% were in the Prasad scale 4 and 73% in the age group of 30 to 40 years. 87% of patients less than 20 years of age reviewed after a period of 7 days. 65% were treated conservatively, 13% needed repair of open injuries, and 21% were patients with guarded visual prognosis who refused to go to a higher tertiary center for adequate surgical repair. A logistic regression model was made to evaluate the visual prognostic outcomes, where age, socioeconomic status, and injury interval were found to be significant in determining visual outcomes. We developed a nomogram score wherein we gave a score to injury interval, socioeconomic status, and age, and we had a cumulative score from 0 to 11. Based on the score, we developed a scale of probability for guarded visual prognosis. The ROC curve was plotted, and which showed a sensitivity of the model of 82.73%. Existing research identifies demographic, societal, and clinical characteristics which help to estimate the prognosis of IPV injury. Current study estimated mean age to be 30 years, which corresponds to different other studies which were conducted outside India, while nearly 40% of patients in the higher socioeconomic groups had good visual acuities. Lower socioeconomic groups had injuries that were more visually threatening. Majority of the IPV injuries affected the conjunctiva, followed by eyelid injuries and vitreoretinal injuries. 65% of victims presented within 7 days. Adequate access to healthcare services has been favorably linked with final visual acuities. The current study also established that injury interval, age, and poor socioeconomic state were inversely proportional to visual prognosis. As we showed before, the predictive nomogram was evaluated, and this can also be used as a triage model in ED settings. The model also helps to identify, screen, and determine IPV victims based on the injury interval and demographics, and helps in evaluation and further referral for ancillary services. IPV injuries continues to be an important cause of ocular trauma, but is severely limited by inadequacy of detection, assessment, and appropriate referral. Early and efficient intervention can aid in appropriate management. Association with demographic risk factors can further help to detect recurring patterns of injury. Limitations of my study were, this study included documented IPV cases, and as mentioned before, IPV is severely underdiagnosed in ER settings. The sample size did not include any male patients, and the sample size did not include subjects from higher socioeconomic strata, and obviously only the patients who had given consent were included in this study.
You have a very limited subset of patients. Your data is
Yes, sir.
greatly
Actually,
skewed to one side.
yes. That was one of the limitations of my study, sir.
Any other comparative studies earlier?
Sir, I did two comparative studies. They established that these factors were linked, but they did not make any predictive model or did not have any scoring system based on it. So,
Yes.
and, studies pertaining to Indian scenarios are very limited.
And your study shows all females, no males. No.
Yeah,
And
I
is
did
it
not
a-
have any male patients. I did not have that as an exclusion criteria, but I did not get male patients.
So is it a global phenomenon or it's?
So it is not a global phenomenon because most of the studies that I have as my references, they did contain male patients. But in my case, I did not have that as an exclusion criteria, but I still did not get it. So,
Thank you.
Thank you.
thank you, sir.
So we'll have the next speaker, Dr. Manisha Agarwal.
So a very good afternoon to all of you. I will be presenting a novel technique for repair of large cyclodialysis clefts. Cyclodialysis clefts are defined as the separation of the ciliary body from the sclera secondary to blunt trauma or as a complication of surgical intervention very commonly encountered after glaucoma surgeries. The extent of the clefts may vary, causing persistent hypotony in the patients. Various techniques have been described for the management of these clefts, such as cryopexy, encircling bands, suturing the cleft, etc. However, there is a paucity of techniques described in literature for the management of large clefts which are more than 180 degrees in extent. So my study was to evaluate the efficacy and complications of a novel technique described as sewing machine technique for the management of large cyclodialysis clefts, and also to evaluate the visual improvement after the cleft repair. This was a retrospective study where all the patients diagnosed with large cyclodialysis clefts from Jan 2017 to January 22 were included, and the demographic profile of these patients was recorded, and the large cleft was defined as more than 180 degrees in extent on gonioscopy and confirmed on doing a UBM. These were my inclusion and exclusion criteria. And I will just show a short video. 14-year-old boy with badminton. Can I have the voice, please? And vision of 624 N24 and a pressure of 2 millimeters of mercury. There was subluxated lens and hypotony. इस वीडियो को शुरू से प्ले कर दीजिए. 14-year-old boy with badminton. So this was a 14-year-old boy who presented with diminution of vision in the right eye with a history of blunt trauma with a badminton racket 4 months back. He had a subluxated lens. I still don't have the voiceover, please.
Here's how a sewing machine works. There's a threaded needle above the fabric. When it pierces the fabric, a rotating shuttle hook below catches the thread.
We present the sewing machine technique to repair a cyclodialysis cleft. Lensectomy and vitrectomy was done, followed by intraophthalmoscopy to confirm the extent of the cleft. A scleral plug was made and 10-0 proline suture was threaded into a 26-gauge needle So after doing this, a post-operative follow-up at 12 weeks, the IOP had increased to 18 mm of Hg, and this patient underwent a secondary IOL implantation at 6 months follow-up and recovered a vision of 6/9 with an IOP of 18 millimeters of mercury. And you can appreciate the extensive scarring secondary to the blunt trauma. Till now, we have repaired 5 cases in a similar way, and the average IOP at the presentation was 3.4 mm Hg, and the average follow-up time was about a year. And the IOP post-operatively, average IOP was 10 millimeters of mercury, and no post-op complications were noted. The etiology of the cleft was blunt trauma in 4 cases and post-trab in 1 case. Therefore, to conclude, large clefts are more than 180 degrees in extent, and they are difficult to treat. Sewing machine technique to repair the large cyclodialysis clefts offers a treatment option to manage these difficult to treat large clefts with no post-operative complications. However, a further confirmation of the efficacy of this technique may require a larger number of patients managed by this technique through a prospective multicentric study. These are my references. Thank you for patient listening.
So just a small question I would like to ask. Like, you're using the 30 gauge needle to hold the sutures outside.
I mean, you can use any needle. That is basically to just keep the loops in place so that they don't go back inside the eye.
I think, won't you think that a blunt instrument will be a better thing?
Yes, you can use that. Absolutely. Anything which doesn't allow the loops to go back into the eye again.
What are the complications you encountered? Any bleeding, vitreous bleeding or some?
Very minimal bleeding can happen because it's a little blind procedure that you are putting the needle, but that clears up in about a week's time. But I have not had a major bleed which required another surgical intervention.
Any retinal tear or
No,
retinal
no.
detachment?
This is too anterior. It's 1.5 mm behind the limbus.
So you have no inadvertent injury to the retina?
No, no, not at all.
Any post-traumatic retinal tear which was there, which may have exaggerated following the surgical intervention?
Not really, because we thoroughly examine the retina before taking up these patients for any surgery because they are post-trauma cases. So we know they are prone to develop dialysis or tears. So we take care of that before planning the surgical intervention.
And you closed it under saline or air?
I close it under saline, yes. Because we are already dealing with eyes with hypotony. So air would not be a good option for them.
Thank you.
Thank you so much.
Dr. Soni Sinha.
The topic is knowledge, attitude and practices regarding ocular protection during gardening among urban homemakers. Over to you, ma'am.
Good afternoon. There are no financial interests. Although it's accepted that gardening is beneficial for physical and mental health, however, there's undoubted evidence regarding accidental ocular trauma during gardening. So there's paucity of literature about the KAP of home gardeners about eye protection during gardening. And therefore, this study was undertaken to determine the proportion of respondents who use eye protection during gardening, to assess opinion of respondents regarding advantages of eye protection, and to enumerate the problems encountered while using protective equipment. So this cross-sectional questionnaire-based study was undertaken among homemakers residing in apartments in urban Patna and among the 50 female respondents. Now, semi-structured questions and demographics characteristics on the knowledge of the advantages of protective eye equipment, their attitude regarding whether using eye protection was necessary during gardening, and practices regarding use of such were taken along with the history of ocular trauma and problems encountered by using the protective equipment. The results were grouped into related thematic areas and represented as percentages. All respondents had a mean age of about 46 years and agreed that some form of eye protection was necessary during gardening. The perceived advantages of eyewear were protection against dust, leaves or grass blades, gardening tools, sunlight, but not against chemicals or fertilizers. The use of protective equipment was not done by almost over 50% of the users, while about some of them used the regular sunshades or prescription glasses, while very few used on-ear protective goggles, goggles with headbands or face shields for the purpose. In fact, 4 of them had suffered in ocular trauma, but 2 of them were still not using any eye protection. The reasons cited thereof were discomfort, poor access and cumbersome maintenance, and difficulty in looking through the equipment. All of them, however, agreed that awareness needs to be disseminated in apartment communities about the same. This trauma with gardening has been occasionally reported in literature with whenever a failure is there to wear eye protection. So in a study among rural agricultural workers, it was found that if they were provided protective equipment at the beginning of the harvest season, the amount of ocular trauma did go down. Accidental injury can occur, which is also accompanied by vision problems and ocular inflammation. So this increase in trauma due to domestic activities and accidents is usually, now increasing, in fact. So in the present study, this protection was perceived as advantage, but nobody not or thought of that chemical injuries from fertilizers, etc., could also lead to eye injury. Now, the designs of not wearing eyewear were cited, but it is well known that ergonomically designed, lightweight, and optically clear protective eyewear is not expensive and can be easily accessed online and offline. So all the respondents agreed about the awareness, and there's a study which reports that there's a kind of herd mentality among workers in the same household. So here also, by analogy, I feel that it may also be true for apartment communities. If we disseminate awareness about eye injuries, then there may be the whole apartment. If one takes up eye protection, the others will also follow. However, there can our ophthalmic associations also have got a role to play in this regard, taking measures to promote awareness activities with emphasis on the correct and regular use of protective eyewear and on following instructions and warning labels on chemicals, lawn and garden equipment. So in addition, the ophthalmic facilities of first contact should also be identified and alerted so they can expedientially act to prevent the irreversible loss of vision should eye injuries occur. Being a pilot study, the limitations are that inferential statistics could not be calculated as they could have yielded no additional useful information. So there's a need for increasing awareness among urban homemakers about comfortable, ergonomic, transparent eye protection equipment suitable for use during gardening, and ophthalmic associations may take measures to promote these awareness activities in urban apartment communities. Thank you for your patient hearing.
Very nice, important point brought up. I think ophthalmologists need to be involved for this awareness. Because very frequently we see in our practice this is going on. Great.
Thank you, sir.
Any questions, anybody of the panelists?
The house, you are saying that homemaker doing gardening, it's basically a hobby for them. So do you took in aggregate time used by every homemaker in the gardening, so that when you are saying that they should think for using the protective, how much average time each homemaker was putting for that gardening?
So it was about 4 hours per day almost
4
for
hours,
2 in the evening in balconies. Yes, they were very affluent homemakers having more than 50 pots in their balconies. More than 40 to 50 pots in their balconies, and tending to them solely, not with house help or external Mali help. They were doing by themselves.
Housemakers will usually have a house help who will do all these things.
Sir, we are now hanging baskets, we are having vertical gardens, so there's a lot of scope in.
That was average time, 3 to 4 hours everybody was putting in the...
Yes, yes,
okay,
2 hours in the morning, 2 hours in the evening. That's what they reported. That's the self-report. There can be bias. I totally agree with you. There can be a bias in this.
And there is no cutoff as to whom the study identifies as gardening, like how many potted plants, nothing like that, ma'am. They can be
So
as
I
low
said
as
that it was approximately 40 to more than 40 plants in the garden. Hanging, vertical gardens, indoor plants, in the balconies, etc. Urban gardeners living in apartments.
What I wanted to ask, whether you took the people who had the balcony gardening or those who had a house with a lawn as well as...
No,
so you took only apartment?
Apartment gardening. this is a new thing, you know, people are more and more with COVID, they have become more conscious about people staying in the house and tending to apartment gardens.
Anyway, thanks a lot. We have the
Thank you,
next
sir.
talk coming up by Dr. Abhijit Beniwal. Is he there? Dr. Abhijit? Yeah. Pinch and snip technique for removal of conjunctival foreign bodies.
Good evening. Good evening, everyone. I'll be presenting my talk on pinch and snip technique for removal of conjunctival foreign bodies. No financial interest. So, blast injuries can lead to impaction of foreign bodies in conjunctiva, and they can serve as nidus for infection. And meticulous surgery is needed to minimize the inflammation. So, we describe a novel technique for removal of these foreign bodies.
Sangeeta.
So, 5 patients with mean age of 17.6 years were selected. So, as you can see here, the foreign body was first grasped with the McPherson forceps, which is to pinch the conjunctiva, and then it was moved up to secure the foreign body, and that would eventually lead to hemostasis. Then the MVR blade was used to snip the conjunctiva, and this led to a smaller cut, which otherwise could have been bigger, and then LIMS forceps was used to remove it. So in all 5 patients, the conjunctival foreign body is removed successfully, excellent hemostasis. And so the McPherson forceps, the aim here is to prevent slippage of palate, otherwise it will keep moving. So we first grasp and pull it, and then it is snipped. And we used AIOC20234 to demonstrate this technique as shown in this figure. It is an effective and simple technique to tackle multiple conjunctival foreign body and doesn't need sophisticated instrument and is easily reproducible. However, we could not, we had very less sample size. So, thank you.
Do you have any video to show? It's only the photos.
Huh?
Okay.
I don't have. It was lost in COVID.
How many cases are there?
5.
5 cases. How many required suturing at the end?
We did not, some of the conjunctiva were lacerated, so that required, but not for the foreign
What
bodies.
was the average size of the foreign body?
Average size, we did not measure it, but like this case which I showed, it was a gunshot injury. So it was a small, like less than 0.5 mm. foreign body.
Only conjunctival was there any
No, there
foreign
were
bodies
there
are
were
in
foreign bodies elsewhere also, but I haven't discussed. Like in this case, the
many
it
times
had-
in the even not even the intraocular, it can be in
It
the
had-
sclera or
Huh.
outer coating.
it had
And what anesthesia you use for removal of foreign bodies?
so 3 cases we did in LA,
Okay.
and 2 children we did in GA.
Okay.
It was on a single foreign body that you have removed, or it is multiple foreign bodies you have tried to do at the same setting?
Multiple
On all
in
the 5
same
cases,
setting. Multiple foreign bodies.
foreign bodies.
These
So
were all
that's
blast injuries.
pinch and snip.
So multiple foreign bodies we removed.
What I was saying, because multiple conjunctival foreign body, especially because of the gunpowder after the blast, or even if the blast is occurred at the slightly away area, then multiple small foreign bodies in the form of stone ones can be there, and you need to remove it in a multiple setting under GA. Many times these blast, in your case also blast, so these are the particles which are hot when they enter the eye, so they enter deep. So it is not only that removing at one time requires, you may have to call the patient for 2 weeks, 3 weeks. You will find the foreign bodies which were slightly deeper, they are coming out. So that is also there. So when you are saying blast injuries and foreign bodies which are multiple, these are not only superficial, they are in the anterior part of the coat of the eye, which you need to look for again after few days. So that is the thing.
In these 5 cases, how many patients underwent a second procedure?
So not for the conjunctival, but for let's say corneal foreign bodies, there were intraretinal also. For that, 3 of them.
But conjunctiva, using this technique, you were able to remove almost everything.
Almost all of them. Some
You needed to convert to the other technique to lift the conjunctiva and then remove, or did you need to convert to the traditional technique of removal, or?
No. From conjunctiva, we try to remove in this way only of all the patients.
Any other investigations you did while doing this? Because if it's a gunshot injury, perforation is a very good chance. and you're doing this under topical anesthesia.
No, no.
And, sorry?
Not topical, sir. GA or under block. If the globe was intact, then under block, and otherwise under GA, sir.
Okay. But no investigations were done prior to that.
In one of the patients, we did VER just to see whether if there is, because there were multiple intraocular foreign bodies also,
Okay.
whether to see any visual potential.
Fine, thank you.
Thank you, sir.
Next is ocular injury in road traffic accidents and its management in tertiary hospital in central Odisha, Sangeeta, Dr. Sangeeta Vasantarai. Let Dr. Sahil Jain be ready. The next person, is he there? Yeah.
Good afternoon, everyone. There is no financial interest. In developing countries, ocular injury is the most common cause of blindness following road traffic accidents. Ocular injury may involve eyelids, lacrimal canaliculi, orbital wall, periorbital structures, conjunctiva, cornea, sclera, extraocular muscles, vitreous and retina. There may be prolapse of uveal tissue, vitreous hemorrhage, choroidal hemorrhage, and globe rupture. These are the causes of visual loss. So this study, we analyze the different types of ocular injury following road traffic accidents and its management both medically and surgically in a tertiary hospital. This is a cross-sectional, non-interventional observational study. We included the patient of age group 10 to 70 years of age. Patients who sustained ocular injury following road traffic accidents are included in the study. Ocular injury due to domestic trauma, chemical burn, assaults are excluded from the study. The study period is of 1 year. Total number of patients were 146 patients. Ocular examination is done in 2 phases. First phase we did bedside examination, and second phase evaluation of patient is done in outpatient department once the patient was ambulatory. Bedside examination included extraocular injury assessment, pupillary response, vision by counting method technology, extraocular movement examination, visual field assessment by confrontation test, and fundus examination by indirect ophthalmoscopy. These are the cases where first case ecchymosis with subconjunctival hemorrhage we can see, second case both bilateral ecchymosis, and third is the lid tear. And these are the cases where we can find lid tear, subconj hemorrhage with corneal tear. This is the rupture globe, and here subconj hemorrhage, and here is the traumatic nerve palsy, and here is the traumatic endophthalmitis. So mainly males are more affected, and most common ocular finding is ecchymosis followed by subconjunctival hemorrhage. 30 to 40 years population are more common presentation, and two-wheelers are most in the risk group. There is 68% patient have influence of alcohol, and 36 patient they use helmet, and 64 patient they didn't use helmet. There is 8% they don't use seat belt in case of four-wheeler, and left eye involvement is more common in this study, and 42 patient they use mobile phone during driving. We manage ecchymosis, subconjunctival hemorrhage, and hyphema medically. Lid tear, corneal tear, and iris prolapse were repaired surgically, and there was a mutilated eye in which we did evisceration, and vision was not recovered in patient with traumatic optic neuropathy. So coming to discussion, in road traffic accident, ocular trauma is the major cause of ocular morbidity and blindness. Male patient with age group 30 to 40 years are the most common victim. Namala et al. In their study showed that two-wheeler riders are more prone for ocular injury, which is very similar to in our study. In other study, right eye involvement is more, but in our study, left eye involvement is more common. And this is the first study which shows the influence of mobile phone use during driving or riding, which is about 46% of cases. And the major cause of vision loss is about 7%, which is similar in other studies. To conclude my study, ocular injury are the most common cause of significant mortality following road traffic accident. Phone use, not following traffic rules, overspeeding, alcohol intake, not wearing protective gears are the major cause of ocular trauma. So awareness about the hazards of the road traffic accident and timely management of the injury can save sites. These are the reference. Thank you.
Did you do a beds classification of the trauma?
Yes, sir.
Was it done, the bed scoring?
Uh,
That is the classification system. You do the trauma scoring. Was the trauma scoring done in these cases?
no,
OTS,
Okay.
OTS scoring. What was the additional information in this studies you?
Sir, this is one part of our study. Another factors we considered the orbital floor fracture or any wall fracture of the orbit, and if it is associated with head injury or not. So this is one part of the study where we manage because when there is fracture of the orbit, we refer to the plastic surgery group. So we have not included that.
Actually, just documenting the use of helmets is not of any use because most people wear non-standardized, non-ISI helmets. Actually, you should include standardized protective wear and non-standardized. A lot of times, the shield of the helmet itself, if it is non-standardized, can cause
Yes,
injury.
they can tear
itself.
the cornea also.
So that should have been documented actually.
Yes, sir. Thank
Also, the timing of the injury should also be documented. When you were saying alcohol intake before night time or daytime, that could have also been
you. Yes, sir.
documented.
Thank you.
Thank you. Yeah. Can we have the next speaker, Dr. Ashok Sharma? Presenting author Dr. Sahil Jain, vitrectomy in eyes with penetrating keratoplasty.
Good afternoon, everybody. So indications for vitrectomy in post-PKIs are mainly retinal detachment, which are iatrogenic only in 2.1% cases to 4.7% lifetime risk, but it's most commonly traumatic. Vitreous hemorrhage, endophthalmitis, and nucleus drop after triple procedures, all of these can be complicated with suprachoroidal hemorrhage. So traumatic wound dehiscence is one of the most common causes of posterior segment complications with vitreous loss followed by vitreous hemorrhage and retinal detachment. The problems with VR procedures in post-PKIs are the graft failure and the graft rejection, and poor post-operative results because sometimes they present late and have severe PVR. More often they are complicated with redetachment, hypotony, and choroidal effusion, and they need multiple surgeries. So coming to the study, so these were the inclusion and the exclusion criteria. Eyes with PK and posterior segment complications were included, and a minimum follow-up of 6 months was noted. Eyes which underwent combined PK or with temporary K-Pro assisted PPV were excluded, and follow-up of less than 6 months was not included. Preoperative data, so the best corrected visual acuity, intraocular pressures, slit lamp examination, indirect ophthalmoscopy, and B-scan wherever the posterior segment had no view was done. Coming to the surgical approach, all the patients were counseled thoroughly as suggested in the previous slide. And these patients had clear corneas in the beginning of surgery, but the graft mostly becomes hazy during the surgery, so the epithelium was debrided. Use of scleral band 240 as encirclage was done in all the cases of retinal detachment in the study. And we coated the endothelium with viscoelastic in AFAK cases, and minimum manipulation was done in the anterior chamber. Posterior vitreous detachment with Kennicott was done, and close shaving of the vitreous base was done, and the ports were always closed because these eyes suffer hypotony quite a lot. So this is a small surgical video. A core vitrectomy is done, followed by Kennicott induction, and a PVD is induced. Complete removal of vitreous is done. Any stapholes or any kind of PVR is segregated. All the breaks are cauterized. And close shaving of vitreous base is done. In cases where we had an epiretinal membrane, ILM peeling was done. Followed by a retinotomy and laser to all the breaks. So coming to the first case, he was a 41-year-old male with a history of PK in 98. Graft was clear till June 22. He had a trauma with fist in June 2022 with the expulsion of the crystalline lens, and the graft was dehiscence. Graft was resutured. He had a retinal detachment later on. So we underwent with a vitrectomy with oil in July 22, but his graft failed in January 2023, so we had done the regrafting. This is the B scan for the patient where we can see the RD. And a buckle 240 with the re-PPV with fluid air exchange, endolaser, and oil tamponade was done in March 2023. So at that time, we did not have the fundus camera. So this is the slit lamp imaging for the posterior segment. And we can see that the retina was attached in all the quadrants on first month post-operative. This is 6 months post-PPV. The graft is fairly clear, but it showed a deficit of about 960 cells in comparison to the pre-op condition. That pre-op condition is before the graft was taken up. So intraocular pressure was 12 and best corrected vision was 6/60 for this patient. This is at 6 months. We had the access to the fundus camera and the vision was 6/60, which is maintained till now. Coming to the case number 2, this was a 60-year-old male with the graft melt. He had post-PK. Therapeutic penetrating keratoplasty was done. He developed endophthalmitis over the next 2 days. So we attempted with a core PPV, vitreous tap and intravitreal vancomycin and ceftazidime. Second day post-op, the graft was fairly clear and the retina was on. We did put a gas in this patient as I was scared of a retinal touch in an area to which I did a laser. But he had a ERM and the retina was fairly on. And there was a ERM as I told earlier. So coming to the results, we had operated 12 eyes till now. 7 had retinal detachment and 1 had RD with serious choroidals. 3 had a vitreous hemorrhage. 1 had a vitreous hemorrhage with hemorrhagic choroidal detachment. 1 patient was of endophthalmitis. Out of all these patients, 1 patient had a redetachment, case number 1. And the follow-up with us is of 12 months to 42 months. All patients at presentation had a visual acuity of hand movement or below. Mean logMAR visual acuity increased from 2.3 to 0.8 to 5 logMAR. And the post-op visual acuity ranged from counting wave close to phase to 6/18. All the 12 patients had the retina attached on last follow-up. 7 patients had a post-op silicone oil and encirculated 240 bands. Graft was clear in 11 patients with 1 had a regrafting. Average endothelial cell loss was 884 plus minus 156 cells, and it was more so in aphakics. Traumatic wound dehiscence was the most common indication for vitrectomy. Retinal detachment was the most common complication, followed by vitreous hemorrhage. Early intervention is associated with a better outcome. Significant endothelial cell loss occurred in comparison to a normal timeline for the graft, but graft remained clear at last follow-up, suggesting good outcome of surgery. So PPV in these eyes with PKP provide good anatomical and functional outcome. These eyes are at a higher risk of a graft opacification, dehiscence, retinal detachment, phthisis, and atrophic bulbi. Need of multiple surgeries has to be explained to the patient, but vision can improve significantly in these patients after PPV. Thank you.
Average duration, please. Average duration of follow?
So we have some patients, minimum follow-up is of 12 months, but we included 6 months as our cutoff. But we have 12 months to 42 months, over 4 years now.
So all your patients had history of trauma?
Yes, sir. All of them which were included in the study had the history of trauma.
And all had detachments after keratoplasty, or it was?
So they had detachment after trauma, sir.
After trauma. So
After
if both the corneal graft is now, dehiscence is there, and retinal detachment, do you do a 2-step procedure or a single step?
So in this study we did a 2-step procedure, but we have done a combined procedure as well. I don't think there is a difference in the kind of results in both of them. I think they behave almost the same. The endothelial cell loss is almost the same in these patients.
In your case 1, the patient status was aphakic at the last follow-up.
Yes, sir.
The aphakic dislocation. A patient was aphakic with the silicone oil.
Yes, sir.
And there was no oil graft touch. How did you prevent that?
So luckily, in none of our patients we had a graft touch. When I put oil, I injected pilocarpine in all the patients to have a small pupil. But even with that, we cannot be sure that the oil can't come. Even with the posterior mesh sutures or with that, the oil comes ahead. I've seen few patients in which the oil comes ahead. So there's nothing actually which we can do really.
In the case 2 which you showed,
yes,
there was a corneal melt or corneal this thing,
yes,
and the POD2 had cornea was clear. So, how, I mean, did you do anything in the first procedure to wash away the corneal melt, or what did you do so that the cornea became?
So the whole AC was cleared.
Okay.
The therapeutic penetrating keratoplasty was done for this patient. On table it was not noted. The vitreous was clear at that time, but in next 2 to 3 days he developed the endophthalmitis.
Mean gap between keratoplasty and your vitrectomy?
Sir, it was from 3 days to, the mean gap was about 12 days, but it was from 3 days to 27 days.
Okay. And if you take that from mean day time from trauma,
The mean time for trauma.
Trauma to your surgery, if you exclude the keratoplasty.
I have not noted that, but
Yeah.
I'll do that now.
Because the detachment outcome depends on that rather than your gap
Yeah,
from
right,
the
sir.
keratoplasty.
Right, sir, right.
Agreed?
Agreed, sir. Agreed.
Next, we are inviting Dr. Rashmita to present her paper on firecracker-induced ocular trauma, trained during and after COVID-19. We'll just see what are the changes has happened in firecrackers after the COVID-19.
A very good afternoon to everyone here. I'm going to discuss a paper which is the trend of ocular trauma induced by firecracker during and after COVID-19. Diwali is synonymous with lighting lamps and bursting crackers. However, it does come with its set of hazards. It is reflected by the high incidence of firecracker injuries in India. Scenes like these are not uncommon in hospitals across this country during Diwali. The first picture shows a picture of a boy who came to us on the Diwali morning with severe burns to his face and ocular injuries. The next video is of an unfortunate case of a 9-year-old who came with a globe filled with sand and debris and grit following close proximity to a bursting cracker. And it is sad to note that the festival of light actually spells darkness in the lives of so many. The reason this happens is because of the substandard fireworks, unsupervised children, alcohol consumption, and an unnecessary display of bravado by the youth in this country. 35% of firecracker injuries involve the face, head, eyes, and ears, and 19% of these injuries are ocular. In 2020, however, the COVID-19 lockdown was implemented, and Diwali saw a drastic drop in the number of firecracker casualties in the country. With the world steadily coming out of the pandemic, the trend of firecracker injuries has reverted. However, this hypothesis is purely anecdotal, and there is no evidence in the form of studies to support it. Possibly, the COVID-19 lockdown influenced the trend of firecracker injuries in this country. However, we cannot keep implementing lockdowns to keep these injuries under check. So what can we learn and adopt from the pandemic to curb the menace of firecracker injuries? We did a review of literature and found that the number of firecracker injuries have been on an upsurge over the past few years, and that there has been no effect of previous government-imposed firecracker bans on the number of injuries either. We designed a multicentric retrospective study. We collected Diwali data from the year 2020 to 2022. We included 1,272 eyes of 1,005 patients who all presented to the cornea clinic at 5 tertiary eye care centers. We included the patients who presented in the 1 week preceding and succeeding Diwali through the years 2020 to 2022, and excluded patients who presented to us during any other time. On analyzing the results, we saw a statistically significant male preponderance in the victims in all centers across all 3 years. We also found that the most commonly affected age group was less than 20 years. The patients presented to us with a plethora of injuries, both open and closed globe. And there was a massive leap in the number of injuries in the year 2022 across all centers, with some centers showing an almost 200% increase. The key points from our results was that there was an almost 3-fold increase in the number of casualties in the year 2022 in most centers. Vulnerable children, young adults, and men were the overwhelming majority of the victims. This is a sad point to note because these men are mostly the breadwinners of many families in this country. 2% of the study population had permanently lost their vision due to these injuries as well. However, a more important perspective would be to look at how drastic was the decrease in comparison to the year 2019. So we took data from one particular tertiary center and compared the numbers. And we could clearly see a 40% decrease in the number of injuries in the year 2020 and 2021, and a rebound effect in the year 2022. However, abolishing the use of firecrackers in this country is not a viable option, because it is deeply ingrained in this country's culture to celebrate with loud firecrackers. As a result, there are numerous substandard small-scale industries that manufacture these unsafe fireworks. And although the government has implemented many firecrackers bans in the past to curb the noise and air pollution, there has never been a law to curtail the increasing number of firecracker injuries. Let's look at what the neighboring developing world is doing. Singapore has introduced a Dangerous Fireworks Act with stringent fines and punishment in case of violation. In Vietnam, firecrackers are unavailable for purchase and only displays arranged by the government are allowed. The government has also relocated thousands of employees from the firecracker industries to agricultural sector. And in Malaysia, fireworks are illegal, and a violation can result in a hefty fine or imprisonment. So clearly, there is a role that regulatory laws can play in keeping these injuries under check. So in conclusion, we would like to suggest some plan of action for the same. We need widespread public education and awareness regarding safe firecracker use. We can use barrier protection in the form of protective safety glasses and maintain a safe distance from crackers. Special emphasis on child safety. Parental supervision needs to be mandatory while bursting crackers. We could shift to a culture of holding safer fireworks displays. And as citizens, we all need to exercise caution and follow government-imposed safety regulations to eliminate this needless blindness. Thank you.
We're short of time, so not many questions are asked now. Okay, let's have the next person. The next session is at 4:20. We have already delayed by 15-20 minutes.
Next, I would like to call Dr. Shubhangi Mahesh. She will be presenting a case on silent threat, chemical injury-induced disc edema.
Good afternoon. I'll be presenting a case of ocular chemical injury, following which disc edema was noted.
Next speaker, be ready, please.
Ocular chemical injury represents 3.9% of ocular traumas in children under 14 years of age and 10 to 22% of all ocular trauma. There are already well-known consequences like corneal opacity, chronic ocular surface disorders, anterior segment inflammation, and cataract. This is a case where disc edema was noted post-chemical injury, which is only a handful of cases are documented. Our patient was a 5-year-old male. He was brought to the casualty 3 hours after a history of button battery being inserted into his right eye. He had symptoms of right eye lid swelling, pain, redness, watering, and frothy discharge. After an open globe was ruled out, the eye was first irrigated with 1 liter Ringer's lactate solution. The button battery, which had leaked, was noted to be pushed back far into the superior fornix around the 12 o'clock position. It was removed using Desmar's lid retractor with LIMS forceps. The battery acid segments adherent to the lid margins were removed, and the eye was irrigated with Ringer's lactate once again. Vision post-tire wash was finger counting at 3 meters in the right eye. The left eye, which was unaffected, was 6 by 6. On anterior segment evaluation of the right eye, there was lid edema with battery particles adherent to the lid margin, evident congestion and chemosis, diffuse corneal edema with a macular corneal opacity from 3 to 6 o'clock within the infranasal quadrant, adjoining the nasal limbus, with an overlying large epithelial defect measuring 3 by 2 mm and 3 cloacas of limbal ischemia. So this was around the Roper Hall classification of grade 2 to 3. There was no RAPD noted at this time. There was no abnormality detected when the eye was dilated under hematropine. The patient was subsequently started on topical medication, topical antibiotics, lubricants, and cycloplegics, and daily sweeping of fornices was done with a glass rod. Despite all the systemic and topical treatment, there was a non-healing epithelial defect. So on day 5 post-trauma, right eye amniotic membrane transplantation was done after ischemic conjunctiva was excised. On post-operative day 12, the conformer was removed and the epithelial defect was noted to be healed. There was possible recanalization and vascularization of 2 to 3 blood vessels, and corneal haze had increased. We started the patient on a low-potency steroid as well. On post-operative day 16, the vision had improved to finger counting at 4 meter and anterior subcapsular cataract was noted. On post-operative day 19, the vision had dropped to finger counting at 3 meters and a grade 1 RAPD was noted. So we dilated the patient since the media had relatively cleared due to the healing of the epithelial defect and settling of corneal edema. And we could see disc edema with hyperemic disc with blurred and elevated margins. No CD ratio could be assessed. The left eye fundus details were within normal limits. So thereafter, pediatric reference was done to rule out COX, and intravenous methylprednisolone was started, a 3-day course as per the weight of the baby. An MRI was done, and it only revealed preseptal edema. After 3 days of IV MPS, the vision improved to finger counting at 4 meters, and there was relative resolution of the hyperemic disc and disc edema. 3 months later, now the vision is improved to 6 by 9, and there's just a symblepharon arising from the upper fornix and the pseudopterygium noted nasally as post-chemical injury sequelae. So we infer that optic nerve inflammation. Yes, optic nerve inflammation in case of chemical injury is not due to the direct effect of the alkali, it's due to the inflammatory reaction due to pro-inflammatory cytokines being released and diffusing to the posterior segment. Tumor necrosis factor alpha has been implicated, so therefore prompt anti-TNF alpha treatment like infliximab within 15 minutes of chemical injury can be used. So in this case, we are suspecting the proximity of the battery to the posterior pole may have led to diffusion of the alkali, triggering the inflammatory pathways. And the patient presented after 3 hours, so possible retention of the small part of the battery could promote excessive inflammation as well. So we would like to do posterior segment evaluation wherever possible in every case of chemical injury if the media permits.
Thanks a lot. We are not asking you questions because we are running short, almost 3 more talks. Mr. Satish, who's the next talk? Yeah, Sitesh Watts is going to speak on advanced rotate and back it out, a novel technique for barbed fish hook removal from the eye. Stick to the time, please.
Yeah. Good evening, everyone.
Thank you very much.
I am presenting on advanced rotate and back it out, a novel technique for barbed fish hook removal from eye. No conflict of interest, no financial interest to disclose. Fishing is not only a pastime job, but a profession for many for their livelihood. Ocular injury due to fish hook is prevalent in many parts of the world, and a very few has been reported in literature. Fish hooks are of different types and varieties. Some are barbed, some are barbless. Various technique has been reported in literature. Exact removal technique depends on the type of fish hook and part of eye involved. So we discussed a modified technique of fish hook removal from perforating corneal injury in an early teenage male. To our knowledge, from literature, such technique has not been discussed earlier. So an early teenage male presented to our emergency after being injured in his right eye by a fish hook while playing, with presentation of diminution of vision with pain and watering from right eye. So this is the preoperative image. At presentation, we can note fish hook in the cornea. So we plan to manage the patient by fish hook removal under general anesthesia, and intraoperatively side put was made by extending the exit point where tip of the fish hook was visible. So fish hook was advanced to some extent and rotated to 90 degrees to free the barb from the corneal tissue, and retracted back and again rotated back to original position and then taken out by a back it out technique. So this is a pictorial representation of the steps. And corneal suturing was done, AC formed, intracameral antibiotic injected, eye patched, fish hook and AC tab was sent for culture and sensitivity. So this is the intraoperative images after suturing. This is the fish hook which we removed. Post-operatively, systemic and topical antibiotic and steroid were given, topical cycloplegic was given. So the outcome and follow-up from day 1 to day 90, this is day 1, showing deep stromal infiltrate around the entry wound and intact overlying injury, corneal iron pigmentation, hazy edematous cornea, streak hypopyon with visual acuity of finger counting close to face. This is week 1, which shows endoexudate. So we started oral antifungal and topical antifungal, and visual acuity was 2/60. This is week 2 with loosening and infiltrate around the sutures. This is week 3 picture. This is week 6 showing almost resolved infiltrate and visual acuity of 6/12 with the pinhole. This is 3-month follow-up showing corneal scarring with reduced iron pigmentation and visual acuity of 6/12. Fishing involves a fish hook which is attached to a string and stick to catch fish by engaging fish hook in the mouth. If entangled in the human tissue, make it difficult to remove or retrieve. So knowledge about fish hook and their removal technique is necessary whenever encounter such patients. Various technique has been described in the literature which are retrograde, string yank method, needle cover method, advance and cut method, clamp and retract technique. So in retrograde method, downward pressure is applied to the shank of fish hook, and it is backed out along the entry of point of entry, mainly used for skin injury and barbless fish hook. Ahmad et al., Naktusa et al., and Balvero et al. Use this technique for ocular injury. Needle cover method is large needle bore is passed and guided over the barb. Fish hook is taken out by retrograde method, mainly used for the posterior segment injury. Grant et al. Use this technique for posterior segment injury. String yank method and advance and cut methods is mainly used for skin injuries, in which in advance and cut, the plier is used to cut the advancing edge, and then the rest of the hook is taken out by back it out technique. Clamp and retract technique, Kelly's forceps is used to clamp and flattened the barb against the tip of the fishhook. Fishhook is retracted back through the entry wound, and Brown et al. Used this technique in an eyelid injury. This is a summary of various fishhook technique removal. Hit-and trial of multiple techniques are generally applied before the fishhook is successfully removed. In our case, we avoided advance and cut technique to prevent iatrogenic trauma. Retrograde or backout technique is mainly used for the barbless fishhook, so we avoided this technique. Needle cover is mainly used for posterior segment. So to conclude, our technique can be used in barbed fishhook if entangled in the anterior chamber. However, if resistance is felt during rotation, it should be avoided. Ophthalmologist needs to be aware of such cases and technique of the fishhook removal for better management of such cases. Thank you so much.
Thank you, Dr. Sitesh. We move on to our next speaker, Dr. Maria Banu Ranjini Shridharan. She'll be talking on a tale of two traumas, visual outcomes in closed globe injuries with and without head trauma.
Dr. Geetumani Sharma also please be ready. Come and see, dais side. Be ready. Once you finish, you can start right away. Yeah, over to you.
Good evening. I'll be presenting a tale of two traumas, which is visual outcomes in closed globe injuries with and without head trauma. The ocular trauma has a wide variety of presentations in an OPD where the patient ranges from a simple contusion to a globe rupture, and the patient has a vision of 6/6 with no perception of light. Our aim of study was to analyze the influence of head trauma in the visual outcomes of the patients who had an ocular trauma, also known as a closed globe injury. It is a type of cross-sectional study or study duration 3 months. Our study had 300 patients, and we broadly classified the patients as group 1 who had both a concomitant head trauma and a closed globe injury, whereas group 2 had 150 patients who had only closed globe injuries. We included age group of 18 to 65 years and patients with severe head trauma with GCS less than 9, and any patients with open globe injuries were excluded in our study. Visual acuity during our first presentation of our trauma and at the end of 2 months was recorded. We analyzed the factors like head injury, lid involvement, and bony orbit involvement, and we also analyzed whether it had any impact on the visual outcomes of the patients. Coming to the results, the age distribution in both the groups, it was predominantly a younger age group of less than 30 years, and it showed a male preponderance. In both the groups, the major cause of closed globe injuries were road traffic accidents. And coming to the ocular manifestations, in group 1, that is who had both a concomitant ocular trauma and head trauma, patients presented with papilledema, whereas in group 2, it was a subconjunctival hemorrhage. We also analyzed whether GCS had an influence on the visual outcomes, in which a very mild head trauma where GCS more than 12, about 56.5% of the patients improved in visual acuity, whereas in moderate head trauma it was relatively less. Visual outcomes in patients with papilledema in group 1, it was about 27.3% of the patients who showed an improvement. In group 2, who had only ocular trauma, 5 patients had either disc edema or papilledema, which could be explained by the bilaterality of the ocular trauma, and it also disappeared by 2 months. We also account that the papilledema may be due to a head injury, which was not actually detected by a radiological investigations. This graph shows the incidence of RAPD in both the groups. Apparently, group 1 had a higher number when compared to group 2. Visual outcomes in patients with RAPD, we analyzed that in group 2, 6 patients did not improve, and whereas 15 patients improved. We also account that in radiological investigations, we noted an intraorbital or canalicular injury to the optic nerve, and certain patients 3 patients had optic nerve decompression, but they did not show a significant improvement at the end of 2 months. As said earlier, we also noted the influence of a bony orbit involvement on the visual acuity improvement in patients, where in group 1, a blowout fracture was most commonly involved, and in group 2, a medial wall was involved. Visual outcomes in patients with lid involvement, the visual outcomes was very good, whereas 56.4% and 74.6% in both the groups showed improvement. Coming to the discussion, presence of head trauma in patients with papilledema had a poor prognostic factor. The presence of RAPD in patients with head injury also had poor visual outcomes, and the results were statistically significant. In our study, we also found that, as described earlier, bony orbit involvement affected the visual outcomes in both the groups, but the results were statistically insignificant. And visual acuity at the end of 2 months in patients with lid injury improved, and the results were statistically significant. So these are our conclusion and take-home messages from our study. Head trauma, when happens along with ocular trauma, has a very important prognostic significance in visual outcomes. And we also use GCS as a scoring system to assess the general prognosis. So the presence of papilledema in the presence of head injury and ocular trauma is a grave prognostic factor to decide the visual outcomes. And when there is an RAPD in association with head trauma is an ominous sign. Bony orbit involvement, if present, it decreases visual outcomes even though the results were insignificant. And lid injuries in our study did not affect the visual outcomes irrespective of both the groups. So we conclude from our study that papilledema, RAPD and bony orbit involvement can be taken as the factors which predicts the visual outcomes in patients who had a concomitant ocular injury and head injury. These are my references. Thank you.
Thanks a lot. Good, very nice points brought out. Let's have the next talk.
Thank you, sir.
And the next person should be ready, Dr. Chintan Shah. This side, please. Yeah, ma'am. Please load your presentation, keep it ready. Yeah.
Good afternoon, everyone. Myself, Dr. Geetumoni Sharma, presenting analysis of placing a prophylactic encircling scleral buckle with primary repair in open globe injury. I don't have any financial interest to disclose. Globe injury can cause significant personal, financial, societal, and medical burdens. The prognosis in severe ocular trauma continues to improve. Conventionally, though, the primary goal in ocular trauma is to restore the globe integrity. There are several studies which have shown the benefits of doing a secondary buckle, but there is few study doing buckle primarily. And in Indian context, there is no study, and so is the need for the present study with the aim of evaluating the result of PSCB at the time of primary repair and to define the factors that lead to the functional failure. It's a retrospective, non-comparative interventional case series of 185 cases from Jan 2005 to December 2018 with ethical clearance being taken. All patients of open globe injury involving 5 mm to the limbus with posterior segment involvement in zone 3 as per the open globe injury classification undergoing repair with number 42 buckle belt exoplant were included in the study. Media in all cases were designated either as clear or not visualized. Patients with less than 3 months follow-ups were excluded, and the study variables as mentioned here are taken. The role of the buckle placement at the time of primary repair is being analyzed in terms of visual outcome, anatomical outcome, subsequent retinal detachment, number of subsequent surgeries, number of functional failure. Visual acuity measurements were done as standards given by Holladay GT and Botello PJ. Standard statistical calculations were done and p-value less than 0.5 was considered significant. In the results, we had 160 males and 25 females in the age group range of 25.9 years. Initial assessment data, we find mean visual acuity of 2200, average posterior extent of eye wall laceration is 7.22 millimeter. There were 23 ruptures, 120 penetrating injuries, 7 perforating injuries, 25 IOFB, 14 eyes were clear media where no RD were noticed till the last follow-up of a mean period of 14 months. Final assessment shows here mean visual acuity of 2200 with average 3.9 line of visual improvement, though the p-value of the initial and final visual acuity is not found to be statistically significant. But the initial and final visual grades comparison shows all the categories to be significant except in the 2040 to 2000 categories. There were 3 anatomical grades where 149 maximum eyes were in the IOP range of more than 5 millimeter mercury. Mean number of subsequent surgeries were 1.6, where subsequent RD occurred in 16 eyes which all had developed media opacities. The reasons for functional failure were macular damage 20, RD with PVR 13 and optic nerve injury 11. There were no complications because of the buckle. So to discuss, all of the previous studies referred to here showed that the cases where buckle were placed had lesser percentage of subsequent RD, and the percentage of cases requiring buckle for subsequent RD gets higher. In our study, we have given buckle in all the cases, and 91.35% did not develop RD traumatically. Disrupted vitreous gel initiates RD. There were significant improved outcome seen in cases where buccal was placed secondarily though, and that too during pars plana vitrectomy. In few studies, it's been found that primarily scleral buccal makes the subsequent PPV a technically safe procedure which significantly improve outcome as in this study. During exploration and repair, the conjunctiva and tenons are routinely dissected and muscles are identified and examined. Placing a scleral buccal at this time is often a straightforward exercise compared with repeating the dissection week or later. Disadvantage of secondary buccal risks the violence recently sewn wound. Fibrosis also forms between the initial repair and PPV, which may further complicate subsequent buccal placement. However, there is also risk for primary encirclage, including excess manipulation of an open globe and improper placement. So to conclude, prophylactic buccal prevents vitreous traction, thereby preventing late detachment, and primary scleral buccal placement during posterior segment open globe repair can salvage and may decrease the risk of subsequent retinal detachment and improve final visual and anatomical outcome. Factors for failure were macular damage, retinal detachment with PVR, and optic nerve injury. Here I feel showing this that I have reached my goal. These are my references, and thank you all for your patience.
Thanks a lot.
So next we'll come to the Dr. Chintan Shah. Please.
Good evening, everyone.
Dr. Prithvi, please come and occupy the dais on the right side, please.
The title of my paper is Impact of Glaucoma on Vision in Children After Blunt Trauma, an Ocular Trauma Score-Based Study. So the most common question that we get as clinician when a child presents to us with a trauma, that what is the visual prognosis? And how do we do that? How do we calculate the visual prognosis? So the ocular trauma score is given by Kuhn that we use to estimate the visual prognosis after 6 months of the trauma. But glaucoma has not been a part of ocular trauma score. But in the author's experience, the glaucoma does play an important role in predicting the final visual acuity. So with that in mind, the study was conducted with an aim to find the utility of OTS in predicting visual outcomes in CGI cases presented with ocular hypertension, and what are the factors which affect the final visual prognosis after CGI. This was a retrospective analytical study conducted at Sadguru Netra Chikitsalaya, and we took the patients of ocular trauma from 2015 to 2022. So any patients, children who presented with acute traumatic glaucoma within a month of trauma were included, having at least for follow-up of at least 6 months. Any other types of glaucoma were excluded. The data collection included the trauma details, the standard demography, anterior posterior segment details, and the management. The standard definitions were used to document the ocular hypertension and glaucoma, and OTS score was calculated at the presentation. The standard statistics and appropriate risk were applied. Coming to the results, the study included 124 eyes of 124 patients with the mean age of presentation being 11.4 years. The majority of the patients, that 88% patients were males. Now coming to the presenting visual acuity, the majority of the patient had poorer visual acuity, while more than half of the patient had visual acuity of grade 4, that is less than 4/200. Now this table represents the clinical features at presentation, and we can see that the patient presented with a variety of plethora of features. Almost half of the patients had corneal edema, hyphema, AC reaction, and cataract at the presentation. And the commonest finding was angle recession, which was seen in 77% of the patients. Now this table represents the ordinal logistic regression to predict the final visual acuity from the ocular trauma score. So what we did here is that we tried to find out the predictability of the score, whether it was better than NPL, better than PL or HM, better than 20/200, or better than 20/50. So these are the visual acuity score grades which are given in the OTS system as well. So here this table we have used only OTS score, and we found that the predictability of estimating final visual acuity was only 43%. So almost in more than half of the patients, the OTS failed to identify or failed to predict the final visual acuity. So now we did the multivariate regression analysis that I won't go into detail, but we found that these are the factors: the cataract, subluxation, severe cupping, macular scar, AC reaction, and the zone 2 or 3 of trauma were associated with the poor visual acuity at the final visit. So based on this, we now in this table, this is the same ordinal logistic regression, but here along with the OTS score, we also included all those covariables which had an impact on the final visual acuity. And we found that it increased the accuracy of the technique to 66%, which was initially 43% only. Now here, instead of using ocular trauma score, we included all the factors which are used in the ocular trauma score system along with other covariables. And this system found that the accuracy increased to 76% compared to 43% based on only ocular trauma score. So to discuss that, we found that traumatic glaucoma indeed has a significant impact on the visual prognosis, and our patients, they had likely to be having poorer vision than what was predicted by ocular trauma score system. Now there are several problems with the OTS, that there is no consideration for the children or the younger age. There is no consideration whether it was for OGI or CGI. And if you see the here OTS score 2, there is a raw score between 45 to 65. One cannot predict the final visual acuity. It can range from NPL to 6/6. So why we think glaucoma is relevant? Because the pediatric glaucoma is quite different. They don't respond to AGM, and the chances of trabeculectomy surgery is very high compared to the adults. Because in the adults, the raised IOP, acutely raised IOP, can be controlled with the medical management alone. Like this is our previous paper where we found that almost 46 patients out of 85 underwent trabeculectomy. This is another paper by Kalamkar et al., where also 24 patients of the CGI required trabeculectomy surgery. So there is very high rate of trabeculectomy surgery in pediatric traumatic glaucoma. Well, limitations are that it's a retrospective study. Several examiners were involved over 6-7 years period. So to conclude that ocular hypertension on presentation is a very important factor which can lead to poor visual outcomes. And the injuries which involve zone 2 or 3, severe grades of AC reaction, severe cupping, cataract and subluxation at presentation are associated with poor visual prognosis. These are my references. Thank you.
Thank you. Thank you.
Next we will invite Dr. Prithvi Chandrasekhar. He is going to present AOS Trauma Award winning paper, which is DOTS on documenting of trauma with smart scopes kit.
Yeah. Good evening,
Dr.
everybody.
Bhavik Panchal also come this side, please, if you are there. Bhavik Panchal. Anyway.
Good evening, everybody. I'll be talking on DOTS, documenting of trauma with smart scope kit. As we all know, eye represents 0.27% of the total body surface and still gets to be affected, the third most affected in trauma and injury. And the visual mobility is high, especially in hires in developing countries, and about 1.6 million go blind due to ocular trauma. So that is why medical history is very important. The ocular examination also is very important, and management is important during this ocular injury. And documentation becomes very important for the treatment that we are going to give and for counseling the patient, because that worry, and then teaching and also medical legally. So as we all know, paper-based medical records are difficult to be, or it's disorganized, illegible, tattered, confused, and EMR takes time consuming and it's very expensive. So not everybody can actually afford the EMR. And it's already given in papers that documentation is very important, and photo documentation is even more important in a trauma case. So as we know in our clinic, it is very difficult for us to do photo documentation due to expensive. Accessibility is not there, availability, bulky, portability and handiness, it's not possible. And not everybody can actually afford this, and that's where our smart scope kit comes in. So this is basically a innovative kit that we have done, in which we have a visual acuity, a smartphone visual acuity, that's an eye handbook, which gives us to check the visual acuity. It has pinhole occluders and plus 10D trial frame. And then there are investigations such as torch, BP apparatus, pulse oximeter, dilatation drops, and other investigation modalities, as you can see here: frozen strip, forceps, sterile 26 gauge needle, cotton swab, etc. And these are all things which you can get in the OPD itself. Then comes our innovations. One is the iverter, which helps us evert the eyelid without touching. And then universal eye speculum over here. This is the anti-segment photography with intraocular lens. Basically, we use a chart paper, and then we use a double-sided tape within it. And once this is done, we use a 15 diopter IOL between the hole created with the paper puncher. So once this is done, we attach this to the smartphone, and then it becomes a macro photography device. So once this is done, we can actually take images of the anti-segment without a slit lamp. So anybody who doesn't have a slit lamp with a photography module, they can use this. And these are all the images which we have taken without a slit lamp. So going ahead with the documentation of anti-segment, we have tonometry in this, and then we have the ASPE gonio where we use a 6 diopter IOL instead of the 15 diopter IOL, and you can use it with the gonio lens to take images of the angle also. Then we have the IOL scope. This is basically just for a mention that we can use 4 30 diopter IOLs all together, combined together, and then you can use this for assessing of fungal hyphae and parasites using this. This is just for a mention. And then we have Scooby-Doo. That's a cobalt blue filtering device. Over here you can see how we attached a blue filter to the ASPE device which we already have, and this can be used to take blue photography. Over here you can see how beautifully a CDLS positive can be recorded without a slit lamp. It becomes very easy and handy in our clinic if you don't have a imaging device in our clinic. And then going for the posterior segment, we have the trash to treasure red cam, where we use a hand sanitizer bottle and cut the bottom of the bottle in such a manner that you can actually fit the 20D condensing lens into it. And the other side is attached with a smartphone. And with this, you can actually start taking images of the posterior segment. Here are a few of the images that has been taken: choroidal rupture, macular hole, foreign bodies. So these make up the whole SmartScope kit. So with this, the results over here, you can see cornea and retina were more affected in the trauma cases which we had over here. Basically, it's an effective kit for documentation of trauma-related findings in places where photo documentation was not done before. It helps in on-spot counseling of the patients, and it helps the doctor in medical legal cases also. It's a new age, innovative, do-it-yourself comprehensive kit which can image findings ranging from anterior to posterior segment, and it is a very efficacious and alternate to the conventional instruments which we have right now. Thank you.
Fantastic. Very nice, innovative things. Very interesting also. Every ophthalmologist should have it. A round of applause. We get an award-winning one. Thank you everybody for this session is over. Now we are starting the next session. Before that, I would like to thank the Chairman Scientific Committee for giving all the panelists. On behalf of all the panelists, I thank the Chairman Scientific Committee for giving us a chance to hold and be judges for this session. Thank you. Thank you, sir. All of you. For the next session.